Hi. So, welcome to today's lecture, and we're going to talk about seizures. And I'm not going to use the word epilepsy because a seizure is not necessarily equal to an epilepsy. All seizures are not epilepsy, but all epileptic episodes are seizures, if that makes any sense. All right, so let's directly jump into it. Seizures can be of two types. It can be, there's going to be a quick video, this is going to be really quick, and it's going to be very concise. You need to have certain amount of background to differentiate between seizures and epilepsy. So I'll give you that before we can directly start into seizures. So an epilepsy is when you do not, or when you're not able to find an pathological cause for the seizure. All right, so there has to be a circuiting defect, that I can say in a very layman term, for us to say that there is a particular epileptic episode and it's not a seizure. All right, so let's jump directly into seizures, because seizures will definitely get into epilepsy as well. So seizures can be of two types. It can be a focal, and it can be generalized. If it's a focal, it can be partial or complete. All right, if it is a simple partial, okay, so we in focal we definitely have as focal, and we have generalized, and in focal we have simple partial or simple focal, and we have a complete partial or a complete focal. Okay, so there are two types. And in simple, or in simple, what the scene is such that in simple there is obviously it's not an epileptic, it's not an epilepsy. Consciousness is preserved, okay, and there is no post-ictal manifestation. Okay, so that's the scene that we have in simple. And simple can be of a lot of causes. Well, it could be, one of them could be obviously a TB, it could be stroke, it could be a lot of causes that are actually predisposing to a seizure. Okay, so it could be stroke, it could be tumor, it could be TB, it could be tuberculoma, a lot of things. The point that I'm trying to make is that the consciousness is preserved. That is, conscious patient, he is going to have an seizure, he is going to have obviously dyscognitive features and stuff like that, but the awareness is obviously there. And the interictal EEG, okay, the EEG is normal. That's very important, that the EEG is equal to normal. Let me use white as the color. Okay, so EEG is equal to normal. Okay, so now once we've seen that simple partial is basically just a response due to probably some other cause and it's not an epilepsy, let's directly look into complex partial. Complex partial seizures, they are nothing but they could be epileptic. Okay, but I'm not saying that it is epileptic for sure. It could also have another cause. Okay, but the thing is that it is usually epileptic because of the fact that very few causes can give you a consciousness of, there could be a loss of consciousness. Very few uh, lesions could be related to a partial or a focal onset seizure with loss of consciousness. So that's why we usually say it is a part of an epileptic syndrome. Okay, also very important, as I've already said, and I've been saying this at least now probably 10 times, that the consciousness is lost in complete seizure. And the reason why it's called complete is because we have loss of consciousness. When you look at the seizure, there's just a particular foci that is involved. Okay, so there are, therefore it's not generalized. But even though it's not generalized, it's focused, it's focal, there is a loss of consciousness. Okay, so that's very important to understand. Also, it's associated with 3A, and the 3A is going to be related to, let me get directly into it. The 3A that is going to be related is aura. There's going to be aura, there's going to be automatism, okay, and obviously there's going to be anterograde amnesia. Okay, now what is anterograde amnesia? Anterograde amnesia is that you've seen something, there is something, and you've forgotten the event, so you cannot convert it into a memory. Aura is basically you have certain amount of sensations, like it's going to be an abdominal aura. Okay, it's going to be a visual aura. You'll have an abdominal aura, you'll have a visual aura, you'll have a sensory motionless stare, or something like that. And automatism is lip smacking movements, that we all know of. Okay, so and all of that kind of stuff. So you will have aura, you'll have automatism, and then you'll have anterograde amnesia in this particular attack of a complete focal or a complete partial seizure. All right, You could call it focal or you could call it partial, that depends on you. Okay, and a very important point that I wanted to make is that there is also going to be a post-ictal phase. So what is the post-ictal phase? Where exactly you're going to have a post-ictal disorientation. Will you have some very severe post-ictal features? May or may not be, but you'll definitely have post-ictal disorientation of the patient. All right, and EEG is definitely positive. EEG is showing a very characteristic spike and sharp. Okay, they're gonna have spikes on the EEG, so EEG is not going to be normal, and usually it involves the temporal lobe. The complete partial seizures usually involving the temporal lobe, and to be precise, is going to involve the hippocampus. Here I have mentioned hippo, so hippocampus, correct. All right, so easy. So that is fine. Is a status epilepticus possible? Yes, a status epilepticus is possible. Now I have brought another term into the entire picture. So what is status epilepticus? Status epilepticus is nothing but when you're having an episode of seizure for greater than 5 minutes, all right, or 2 episodes with no gap, or very important, all right. So if you're having a status epilepticus with which is greater than 5 minutes, or you're going to you're having 2 seizures or 2 episodes of seizures or recurring seizures without an return to the baseline consciousness, with no gap, everything is just going on. What I mean by no gap is that there is no post-ictal state where you are having a normal brain function or brain consciousness or baseline consciousness. You're having 2 seizures with no regain of consciousness, with no gap. That's what I mean. All right, so that is basically status epilepticus, and status epilepticus can be possible. All right, it can be possible. Is it possible? Well, see, I'm saying it's a focal. Okay, so there is just a foci involved. So that's why usually we do not talk about status epilepticus, because there has to be a generalized, there has to be a complete seizure. But yes, obviously we can say that. Okay, now coming to generalized seizures. Now generalized seizures can be of different types, as I've already mentioned out here. We have your myoclonic seizure, we have your tonic-clonic, or you can also call it as the grand mal. And this is something that it's very popularly spoken about, grand mal epilepsy. Or it could be an absent seizure, it could be an atonic seizure, and we'll look into each of these variants obviously. So grand mal is something that is tonic-clonic, petit mal is something that is absent. So all these, some people want to look fancy, so they call it petit mal instead of just calling it absent. Grand mal instead of just calling tonic clonic as grand mal. All right, so let's directly look first into the absent, or obviously if I want to look fancy, I'm going to call it as petit mal. All right, so absent seizures can be of 2 types, obviously the typical and the atypical. The absent seizures can be of 2 types, as I've said, but the difference between them is not very much profound. Obviously typical is going to be associated with loss of consciousness, even atypical might be associated with loss of consciousness, and there is obviously a more profound motor sign. Okay, and it is more longer. So atypical is having a motor sign is longer, and loss of consciousness is also longer. So plus loss of consciousness, LOC, loss of consciousness for longer duration, increased. Okay, but when I'm talking about an that is basically atypical. Okay, but what about the typical? The typical is basically loss of consciousness, loss of posture. Okay, there is loss of consciousness, there is loss of posture, and there is no post-ictal manifestation. No post-ictal manifestation. Well, usually you would have thought that all generalized seizures would have a post-ictal manifestation. Well, that's not the case. Complete does have a complete partial seizure has a post-ictal manifestation in spite of it not being a generalized seizure. So there is no post-ictal manifestation in the absent seizure for now. That's what we are looking at. Okay, so how is the patient going to present with? The patient is going to be a 6-year-old child. He's going to be a 6 to 10-year-old kid, and the patients complain to you that, you know what, this patient, my son or my daughter is always disoriented, not interested in class, he just disappears, he is in his own world, she is in his own world, they are in the world of their own mystery. And when you ask the kid is just unaware of all of these complaints. He doesn't understand that why are people actually talking about all of it, while he's trying his best to pay attention and stuff like that. And also there is a very peculiar finding that is very important, is that hyperventilation can usually precede or can usually lead to absent seizure. So it's very important that hyperventilation is kept in mind, because when you ask the patient or when you ask a child to hyperventilate and it's going to cause a loss of consciousness, or then people and then the parents are going to complain that the child is zoning out on hyperventilation, and that can directly lead you to your diagnosis. All right, then the second very important seizure that we are looking into, or going directly to tackle, is this myoclonic type of seizure. And myoclonic is basically quick repetitive jerks. Okay, there is a quick repetitive jerk that is going to occur. So when you're looking at the different seizure classification, myoclonic, tonic-clonic, and atonic, myoclonic is the most intense variant, because myoclonic is the most intense type of movement. You're going to have very rapid seizures. It's as if something is just traveling up your arms. Okay, uh, but it's not that. It's just a seizure. Okay, so myoclonic seizure is a very important part of seizures, and it's a part of GME, juvenile myoclonic epilepsy, where the upper limbs are involved more than the lower limbs. Very important to know that the IQ is normal in particularly these children. Okay, now why am I talking about children? Because juvenile myoclonic epilepsy, something in the juvenile age group. Okay, it is triggered by a decrease in sleep. It is very important that you take good sleep, because it's triggered by a decrease in sleep. And it's also associated with LGS. LGS is nothing but Lennox-Gastaut syndrome. Okay, Lennox-Gastaut syndrome. Very important to note is that there is no loss of consciousness. Very, very important. So basically it can be a component of LLGS or GME, but there's no loss of consciousness. And if you want to treat this, you want to use your drug of choice as valproate. You can use valproate in all types of seizures. Technically, valproate is the number one drug. It's a sodium channel blocker, and obviously it can also block certain amount of calcium channels. Sometimes it's proven. So it's basically a sodium channel blocker, and it's going to cause, it's the best type of drug for treatment of seizures, but it obviously has its own side effects. Correct. So that is for myoclonic epilepsy. Myoclonic epilepsy, as I've said, there's no loss of consciousness, and it is associated with a lot of sleep deprivation, and IQ is normal. It's usually seen in adolescents, and that is about it. And now let's look at the atonic seizures. Atonic seizure is loss of tone, so suddenly the patient is going to just fall to the floor, and people mistake it to be a syncope. Well, it can be a syncope. Therefore you need to differentiate between syncope. Will it have a post-ictal manifestation? Yes, it might have a post-ictal manifestation, and also it is associated with LGS. Very important to get an EEG done during an atonic seizure, probably just to figure out if it's a syncope or it's a seizure. Not getting much into why it is occurring and stuff like that. We'll directly move into the next very important, which is the most discussed type of seizure, that is a grand mal, or GDCS, generalized tonic-clonic epilepsy. Seizure. Okay, now what are the characteristic features that you see in a GTCS? Nothing about this. The very classical complaints that you usually see, because GTCS is the most common time. Most of the time people just be like, oh no, we have seizures, we have epilepsy, and we say that epilepsy is equal to GTCS. Well, that could be a case. Usually when an epilepsy occurs, they all present with the following, and this is the classical thing that we have ourselves also built in our minds. Okay, so first of all, you're going to have tongue bite, you'll have a stiff tonic-clonic seizure. Yeah, obviously the post-ictal symptoms are going to be positive. Yeah, so you're going to have obviously you'll have frothing, you'll have disorientation, you'll have headache, you'll have muscle pain, you'll have severe muscle pain, and you'll have urinary incontinence during the entire episode. So there are three phases. First, you might have a very aura kind of a feature. You might or might not have aura. Mostly will not be here, because aura is usually a thing that is seen in a complete partial seizure. So aura will not be here. So next stage will be obviously your status epilepticus, or your episode of seizure. Okay, your episode of seizure. I cannot say status epilepticus, because the definition, obviously, as I've told you, is going to be greater than 5 minutes. Then only I wouldn't put it as status epilepticus. So I'll put a condition out here that it has to be greater than 5 minutes for me to say it is a status epilepticus. Let's say it is greater than 5 minutes, and I'm saying it is a status epilepticus. So you're going to have symptoms like you'll have alternative tonic, and then you will have a clonic. Okay, so first there'll be increased tone, then there'll be increased contraction. All right, so tonic clonic movements. Okay, plus you'll have tongue biting. Okay, you'll also definitely see a lot of cyanosis, and you will see frothing. Okay, you'll see a lot of frothing, You'll see a lot of tongue biting, as I've already said. You'll also see urinary incontinence. You will see urinary incontinence. Okay. After that, you'll have your very important stage, that is your postictal stage. And as I've said, that postictal stage is definitely present. Any disorder where postictal stage is not present is basically your simple partial seizures, where postictal stage is not present. And a very important is also that in absent seizure, you do not have a postictal manifestation. Okay, so your postictal manifestation is not there in an absent seizure as well, which is your petit mal. All right, so postictal manifestations will be there. You will have disorientation, you will have disorientation, you will have sleep deprivation, sleep issues. You will also have intense muscle ache. You'll have intense muscle ache. Also, sometimes there might be rhabdomyolysis in case there is severe muscle destruction, and that's usually seen in myoclonus epilepsy. Okay, so let's keep that reserved for myoclonic epilepsy and not bring it up here. All right, and very important it is that we do the EEG. Obviously, EEG is going to be very characteristic of a seizure of an epilepsy. Okay, so this is how the episode of a GTCS would look. Now, GTCS could have two causes. It could be an epileptic syndrome, or it could be one of those different syndromes that we all have. Okay, so first of all, it could be associated with alcohol, it could be with barbiturate or benzodiazepine. Usually barbiturate more than benzodiazepine, barbiturate withdrawal or alcohol withdrawal, any of these. Okay, obviously it could be due to a stroke, it could be due to a tumor, it could be due to hypocalcemia, hypoglycemia, hyponatremia, hypomagnesemia, hypernatremia, hypophosphatemia. So hyperphosphatemia is going to cause increased phosphate. Increased phosphate is going to bind with calcium, and when it binds with calcium, it's going to cause hypocalcemia. Obviously, these metabolic and these electrolytic abnormalities like hypocalcemia. Why is hypocalcemia causing it? Because calcium is needed for your nerve action potential, and if calcium is not there, your nerve action potential is going to fire. All right. Similarly, hyponatremia, hypoglycemia as well can trigger one of your seizure episodes. Again, hypoglycemia is quite commonly associated with seizures, and we have noticed that. Obviously, drugs like lithium is a very important antipsychotic medication, tricyclic antidepressant, TCA. You obviously theophylline, cefepime, imipenem. All of these are antibiotics. Obviously, it can be associated with NORS. NORS is viral encephalitis. Okay, and virus encephalitis is basically by herpes simplex virus or Japanese encephalitis 1. Or it can also be associated with an autoimmune disorder like an anti-NMDA antibiotic, which is called as autoimmune encephalitis. All right, or it could be also paraneoplastic encephalitis. Paraneoplastic encephalitis, if you want to talk about, it's basically your small cell carcinoma, SCC, that is the small cell carcinoma of the lung, which is actually releasing a very important antibody, which is your anti-WHO antibody, very important anti-WHO antibody. Now, these anti-WHO antibodies actually cause paraneoplastic encephalitis. Okay, and these can also actually lead to your status your GTCS. Okay, now coming to certain other conditions, obviously, first is the West syndrome that I want to talk about. West is an infantile spasm, and it's usually lead to salam spasm. What is salam spasm? Salam spasm is flexion of the lower limbs, also flexion of the upper limbs, and straightening of the arms. Okay, and flexion of your spine. So basically, it's like you're bending towards and saying salam to someone. Okay, salam sab kind of thing. So that is basically your West syndrome. West syndrome is associated with brain hypoxic injury during birth. Also, it's associated with TBS. Brain hypoxic injury, when can it occur? It can occur in a large for gestational age baby. Shoulder dystocia, which is causing the hypoxic damage in the baby during the passage during the vaginal canal, a lot of cases. So this is just a very big overview that we are actually looking into. So these are the different DDs that we should have when there is a particular scene. And definitely West syndrome is very characteristic. If you see a infant if you YouTube it, if definitely you check it out, you could see that the infant is actually having like elevated with flexions at the hips, flexion at the elbow, arms raised forward, flexion of the neck and trunk, completely. So he's trying to bend both ways. All right, and then you obviously have a very important LGS. LGS is Lennox Gastaut syndrome that we already spoke about. I told you it is associated with myoclonic, atonic, but atonic is the most common, where you have sudden drops. All right, it's associated with severe mental retardation, and EEG is very characteristic. All of these have a particular EEG finding, except of your simple partial epilepsy. Sorry, simple partial seizure. A very big error on my part. Okay, it is usually symmetrical, and it's one of the most severe. LGS is one of the most severe childhood seizures that we have, and very difficult to treat as well. Okay, so you need to go a lamotrigine valproate kind of a drug regime for one of these. And I think that is about it when we are talking about seizures. Thank you very much.